1 second. I'll start. I'll give a start. I'll start now.
Yeah.
Good afternoon, everyone. Thank you all for joining us today. It gives me an immense pleasure to introduce my mentor, Dr. Saroja Murali, who has been an extraordinary source of inspiration and guidance in our journey. Dr. Saroja Murali is a senior consultant in obstetrics and gynecology with of experience of 25 years in clinical practice. With experience of 25 years, and their contribution to the medical field is immense. Not only she is a highly skilled professional, but also a dedicated teacher who always encourages us to think critically and grow in our field. We are incredibly fortunate to have them us today. Please join me in welcoming Dr. Saroja Murali.
Good afternoon, everyone. Thanks a lot, Dr. Divya, for giving such a pleasant introduction and for giving me an opportunity to be part of this online educational discussion. Welcome, Pranjal. Go ahead and present your case.
Good afternoon, everyone. I'm Pranjal, a final year M.B.B.S student studying in Rajrajeshwari Medical College. I'll be presenting a gynecological case today. 44-year-old Rekha, coming from Vijayanagar, who studied till 10th standard and is a housewife by occupation. Husband's name Shekhar, who's 50-year-old, also studied till 10th standard, works as a factory worker, earning 15,000 rupees per month. They belong to upper lower class socioeconomic status according to modified Kuppuswamy classification, was admitted on 26th October 2024 and was examined on 29th October 2024.
Okay, go ahead and finish your presentation, Pranjal.
Okay, ma'am. She came with the chief complaints of pain during menstruation since 8 months and heavy menstrual bleeding since 8 months.
Okay.
The patient was apparently normal 8 months back, after which she started experiencing pain during menstruation. It was insidious in onset and gradually progressed during the cycle. Cramping type of pain, which radiated to the back and thigh. She also complained that the intensity of pain increased from her previous cycles. It aggravates 2 days before menstruation and is present throughout the cycle and stops 1 to 2 days after the end of the cycle, not relieved on medications. Patient also complains of heavy menstrual bleeding since 8 months, associated with passage of clots. She complains of waking up in the night to change her pad. She uses 7 to 8 napkins per day. She complains of tiredness throughout the day and unable to go to work on these days of menses. She has no history of increased urinary frequency or urinary retention. No history of constipation. No history of vaginal discharge. No history of abdominal mass. No history of mass per vagina. No history of bleeding disorders. She has no history of intake of anticoagulants. No history of chronic liver disease. No history of IUCD insertion. No history of significant weight loss. No history of intermenstrual bleeding. No history of postcoital bleeding.
Okay.
Coming to her menstrual history, she attained menarche at the age of 11 years. Her past cycles were of 3 to 4 days duration, regular 28 days cycle, uses 2 to 4 sanitary napkins, no passage of clots, no history of dysmenorrhea. Her last menstrual period was on 12th of October 2024. Currently, since 8 months, she's been having 8 to 9 days of cycle, using 7 to 8 pads with dysmenorrhea and passage of clots. Coming to her obstetric history, 22 years of married life, non-consanguineous marriage. Para 4 and living 4, all children are alive and healthy. Patient has not undergone sterilization and there is no history of IUCD insertion or usage of OCPs. Past history, no history of medical interventions, no history of surgeries in the past. She has no history of diabetes mellitus, hypertension, tuberculosis, asthma, and epilepsy. No history of thyroid disorders. No history of blood transfusions in the past. Family history. No history of similar complaints in the family. No history of any bleeding disorders. No history of diabetes mellitus, hypertension, tuberculosis, asthma, and epilepsy in the family. And no history of cancer syndromes in the family. Personal history. She consumes mixed diet and appetite is normal. Bowel and bladder habits are normal. She has disturbed sleep during her menses. And there is no history of contraceptive use or OCP pills use.
Pranjal,
Yes, ma'am.
at the end of history taking, what do you think you're dealing with case? Which case is this?
Ma'am, based on the history, it seems to be an abnormal uterine bleeding.
Okay, go back to your first slide.
Yes, ma'am.
Abnormal uterine bleeding, there are many causes, right? What is abnormal uterine bleeding?
Ma'am, bleeding from the genital tract that differs from normal guidelines given by FIGO, which is change in duration. Normal duration is 4.5 to 8 days, or increase or decrease in volume. The normal volume
That's the
being
first slide.
yes, ma'am.
Yeah. Okay, then what are the other parameters?
Volume of blood loss, which is normally between 20 to 80 ml.
Okay.
And variation of cycle between two cycles is 2 to 20 days. And duration of cycles is 24 to 38 days, normal.
Okay, what is the importance of age, 44 age?
Ma'am, it is...
your case. Probably would be reaching some diagnosis at the end of history, and which will go along with the examination in line with the history and examine and investigate. Okay, so what is the importance of 44 years age?
Ma'am, this could be considered to be around perimenopausal age, and during this age, uterine fibroids, adenomyosis are more common pathologies seen in women.
It's more common among these two. Is adenomyosis is more common, or fibroid is more common at 44?
Ma'am, adenomyosis is more common.
Yes, adenomyosis in the older books described as syndrome of F, that is female 40 fertile. So it is 40 to 50 age group is commonly we come across adenomyosis, whereas fibroid is a disease of a little younger age group, 30 to 40s, right? That is one thing. And what about her socioeconomic status? Is there any point?
Ma'am, she belongs... Ma'am, usually lower class socioeconomic status are more prone for pelvic inflammatory diseases or cancer cervix, whereas higher classes are more prone for endometriosis or endometrial carcinoma.
Your case is AUB. That too, you have given details about heavy menstrual bleeding, right?
Yes,
so,
ma'am.
What if she belongs to affluent society? What comes to your mind first? Is it fibroid or adenomyosis?
Fibroid, ma'am, increased estrogenic state.
Yes, both are hyperestrogenic state, though. So, what are the other associated conditions of hyperestrogenic status?
Ma'am, endometrial hyperplasia, endometrial cancer.
Okay, so go to the next slide. Okay. So her complaint is pain during menstruation.
Yes,
That's
ma'am.
called as medical terminology is
Dysmenorrhea.
dysmenorrhea, right?
Yes, ma'am.
Types of dysmenorrhea.
Ma'am, there are two types, primary dysmenorrhea and secondary dysmenorrhea. Primary dysmenorrhea is spasmodic type of dysmenorrhea, which starts...
Good.
It starts just before menstruation in the absence of any pelvic pathology, and the pain increases in intensity and it decreases by the second day of her menstruation.
So dysmenorrhea is more characteristic feature of which condition? If a woman comes with both, because you mentioned dysmenorrhea is her first symptom.
Yes,
right?
ma'am. Dysmenorrhea goes more in favor of adenomyosis.
Okay.
Right.
So what about fibroid? Do they have pain or do they don't have pain?
Ma'am, usually it is their main complaint will be heavy menstrual bleeding. They don't present with pain Usually they don't.
If at all a woman with fibroid present to you with pain, what are all the conditions? What are all the problems or what are the things you will think of in a fibroid case?
Ma'am, maybe the fibroid
As I said, most of the times it is 80% of the fibroids are asymptomatic, and if at all they present, the main symptom would be
heavy
menorrhagia.
Yes, ma'am.
And if they present with dysmenorrhea, it is a kind of congestive dysmenorrhea, not as severe as dysmenorrhea, which brings the patient to the physician, right?
Yes, ma'am.
So if at all they come with severe pain in a case of fibroid, diagnosed case of fibroid, what are all the problems or what are all the things you come to your mind?
Ma'am, the fibroid could have undergone any degenerative changes or
Which type of degeneration gives rise to pain?
calcific degeneration.
It's
More,
not common.
more commonly, hyaline degeneration is seen.
Anything else which you come across during pregnancy also?
Red degeneration comes with pain
Any
and fever.
any other time the red degeneration can come across other than pregnancy?
I'm not sure. Infections.
And when a woman is on oral contraceptive pills, so not necessarily only during pregnancy, even outside pregnancy during her puerperium, and when she's on OCPs also, she may go through this red degeneration. And what is the treatment for red degeneration? You're going to do any surgery, or you're going to manage her conservatively? She's pregnant now.
Ma'am, manage her conservatively. Reduce her fever and pain.
Okay. Other than this, leave apart red degeneration, because our patient is 44-year-old and we are thinking in terms of either fibroid or adenomyosis in a fibroid in a non-pregnant patient. What are all the causes of pain in fibroid?
Ma'am, in certain subserosal fibroid, there could be a torsion.
That is a very rare occurrence. Okay, that is one possibility.
Any sarcomatous change.
What is the incidence of sarcomatous change? Is it so common? What is the
No,
incidence?
less than 10%.
Not so high also. Less than even 0.5%, not 10%, right? So rare, but not very uncommon to see pain, they present with pain. And if there is any submucosal fibroid, what can happen, which can give rise to pain? When the submucous fibroid is there and it undergoes polypoid change and trying to become polypoid, so woman will give characteristic history of pain, that kind of abortion pain, that is something is coming out. Submucous fibroid during the process of expulsion or when it is becoming polypoidal, they will have kind of pain, spasmodic severe pain when they become polypoid and present in the cervical canal or even in the vaginal canal. Understand?
Okay, ma'am.
Conditions where fibroid can present with pain. And what is triple dysmenorrhea?
Ma'am, it is pain before, during, and after menstruation, classically seen in endometriosis and adenomyosis also.
Any other conditions?
No, ma'am, I know only these two conditions.
What about PID? There will be congestion, there will be adhesions. What about pelvic congestion syndrome? Heard of pelvic congestion syndrome? Whenever there is pelvic congestions, adhesions, you are likely to get pain even before menstruation. So these two are you have to add onto your list. Okay.
Okay, ma'am.
So how will you treat dysmenorrhea?
Ma'am, NSAIDs is the first line of treatment.
Okay.
If it is spasmodic type of dysmenorrhea, then you can also tell for hot packs and conservative treatment is done.
Okay, fine. So now coming to heavy menstrual bleeding. So what are the criteria to define that it is heavy menstrual bleeding? You said that she has heavy menstrual bleeding since 8 months, right? What are the criteria to define a heavy menstrual bleed?
Change of pattern of the number of pads that she used to use before compared to now suggests she has heavy menstrual bleeding, and also she's complaining of passage of clots.
What is the normal criteria of changing pads? How
Ma'am,
often we expect a woman to change pads? When do you say it is abnormal?
when she's changing more than 4 to 5 pads per day.
Or in other words, she has to change less than 3 hours. A pad needs to be changed less than 3 hours. It is abnormal. But again, that depends on women's perception of her cleanliness, her hygienic condition. Some women may not wait till the pad is fully soaked. You understand?
Yes, ma'am.
These are all very comparative and very subjective. Understand? So
Okay.
there are definitive methods to say, we'll come to that. So that number of pads changed, and any other criterias?
Passage of clots.
Okay. Why do you think passage of clots is abnormal?
Ma'am, in normal menstruation, the fibrinolytic activity of the endometrium is sufficient to not cause clots, but when the bleeding is more, the clotting factors are not sufficient.
Okay. The system is overwhelmed, so she tends to pass. Is any size clot is significant? What is the significant size of the clot to say that it is abnormal? Have you heard of pictorial assessment?
Yes, ma'am. Like India
What
follows
size of the clot they mentioned?
50 paisa size.
Ah,
Which is
1 it will be at least more than 1 inch, 2.5 centimeter and above. So
Yes.
very small clots may not be significant. So you should ask the size of the clot also.
Okay, ma'am.
Then quantity, duration you said, right? Duration in terms of duration?
It is prolonged, ma'am, from her previous cycles. It was 3 to 4 days, and now it is more than 8 days.
So before you asked about all this, did you ask her about history of any preceding amenorrhea? She's 44 years and not sterilized. Is it important to know? You said she's in perimenopausal age group. But the latest definition is she's still in, according to me, in reproductive age group. And all the more she's not sterilized, you must ask history of preceding amenorrhea, right?
Yes,
So what
ma'am.
you should ask history of preceding amenorrhea?
To rule out pregnancy.
Yeah, pregnancy complications are the commonest causes of abnormal uterine bleeding in the reproductive age group, right?
Okay.
What are
Yes,
the
ma'am.
other causes of menstrual abnormalities in the reproductive age group other than pregnancy? Pregnancy will be the first one. Next would be infections, and then benign lesions in the genital tract. And then comes malignancy, then iatrogenic, secondary to use of contraceptives and all that, right? So it's always important to take a last menstrual cycle, a period LMP history and rule out pregnancy. It's mandatory, okay?
Okay,
Even
ma'am.
if they say that they're sterilized many times, we may have to do. Even if they say that young girls comes and they say that they're not in sexual contact, though sometimes they deny, sometimes they tell lies. So it is important to take a good history and rule out pregnancy.
Yes, ma'am.
Next. Okay, this is all. Okay, presenting illness. Okay, explain me that I didn't go through that slide. Can you focus again?
Yes, ma'am.
History of presenting illness.
Yes,
Okay,
ma'am.
radiating to back and okay. So it aggravates 2 days before. That is typical of congestive dysmenorrhea, right?
Yes, ma'am.
Okay. Next slide. So is this all negative history you've taken, right?
Yes, ma'am.
Looks like you have taken quite a good negative history. Hope you know all these, the importance and the significance of all these negative history.
Yes, ma'am.
So can you explain me each one? Why you have taken?
Yes, ma'am. I have asked history of increased urinary frequency and urinary retention to rule out any pressure symptoms that is usually caused by fibroids.
Okay. When do you get retention and when do you get increased frequency in case of fibroid uterus?
Ma'am, in case of increased frequency is seen usually in anterior cervical polyp, whereas
Right.
the polyp falls on the bladder.
In the lower corporeal, or if it is even in the fundus, sometimes when it in the lower corporeal region where the bladder is situated in the anterior surface of the lower segment of the uterus, it irritates. Thereby, it causes increased frequency. Urinary retention,
Is seen in a posterior cervical fibroid.
even the corporeal, lower corporeal, posterior corporeal, when it becomes heavy and when the uterus falls back into the pouch of Douglas, what happens?
It pushes the cervix against the pubic symphysis and stretches the bladder.
Not the bladder, urethra. So the uretrovesical angle is disturbed, altered, and so she cannot initiate the act of micturition. So
Okay.
there is retention. Can you name any obstetric conditions with a similar scenario, the similar complaints they may present to us?
Ma'am, in case of retroversion of the uterus,
Retroverted gravid uterus. Can it be self-corrected, retroverted? Do we need to treat, do anything?
no, ma'am.
No, you just leave her alone? She'll have retention and associated problems. So how to treat?
Not sure.
We should encourage her to lie down prone, because uterus up to 12 weeks, it's not an abdominal organ. Till then, you can encourage her to lie down prone. And once uterus becomes an abdominal organ, 14 to 16 weeks onwards, it gets automatically corrected. Auto correction will take place.
Okay,
You
ma'am.
understand? Whereas in gynec case, we cannot just leave it. We need to do, I have seen, we have operated even young girls coming with the fibroid uterus and the posterior wall of the uterus with urinary retention. We need to operate, or we need to do something to treat them. Okay. Why history of constipation?
Again, it's a rare cause of pressure symptom due to a fibroid.
Okay.
No history of vaginal discharge to rule out PID.
Okay.
No history of abdominal mass.
What vaginal discharge you mean?
Ma'am, in cases of a PID or any infected polyp,
Like only PID? What other history, if at all you think PID is the cause for her menstrual problem? Along with vaginal discharge, what other history you should have elicited?
history of fever, ma'am.
And
Pelvic pain.
yeah, and backache, lower abdomen pain, and infertility. You understand?
Yes, ma'am.
Okay. Abdominal mass, what masses you are expecting?
It could be a fibroid, that could be
Anything else can present as can present as vaginal discharge other than polyp, and you said only PID. Anything else?
cancer cervix, ma'am.
Yeah, very good. So CS cervix you have to rule out in India, because that is the
Most
most
common
common
cancer.
cervical cancer. Okay, we have to always think of CS cervix, and we have to rule out genital tuberculosis, tubercular ulcer over the cervix, and sometimes, uh, uh, this one, uterovaginal prolapse with decubitus ulcer.
Yes, ma'am.
Okay, so that also we have to keep it in mind before we proceed with the examination, right?
Yes, ma'am.
So all the causes for vaginal discharge. So then you asked about mass per vagina. So what masses you wanted to rule out?
Ma'am, it could be a cervical polyp or a fibroid that is descending downwards.
That is again a fibroid polyp. Okay.
And a prolapse.
At the decubitus ulcer.
Yes,
History of bleeding disorders you have asked, right?
yes, ma'am.
So how did you ask? How did you elicit that history? Like,
Ma'am, I asked her if she was diagnosed as a congenital or acquired cause of
what is the acquired cause,
acquired von Willebrand's disease or any leukemia.
Acquired. Von Willebrand's disease is an acquired condition. Can we acquire it? Can you and me acquire von Willebrand's disease? It's inherited, it is congenital, and acquired disease like thrombocytopenias, equality to platelet defects, ITPs. What is ITP?
Immunothrombocytic
Okay. So what are the congenital bleeding disorders? One you said von Willebrand's disease.
any leukemias,
Leukemia is again, okay. Leukemia rarely, they can also present with menstrual problems.
any factor 10 deficiency.
Okay. So how did you elicit the history? How do you ask her?
Ma'am, I asked if she has bleeding from any other sites like epistaxis or any bruising.
Okay. And bleeding gums,
Bleeding gums, yes, ma'am.
purpura, easy bruising.
Yes,
Okay,
ma'am.
okay, fine. History of intake of anticoagulants. How did you ask her?
I asked her if she had any previous history of valve replacement therapy or if she had a history of stroke or MI in the past so that she was put on anticoagulants.
Okay. And how does chronic liver disease leads to menstrual disturbances?
Ma'am, if there is any liver disorder, the clotting factors, vitamin K that is produced in the liver, like factor 2, 9, 7, 10, are deficient. Also, in chronic liver disease, if it goes into a decompensated state, then the patient could have portal hypertension and thrombocytopenia.
And hyperestrogenic state. You see liver disease, cirrhosis, patients coming with spider neve and all those, no, they are hyperestrogenic states.
Yes, ma'am.
Hyperestrogenic states can also give rise to adenomyosis and fibroids and things like that. Understand? So dual mechanism there. So what kind of IUCD insertion causes menstrual abnormalities?
Ma'am, it increases the production of plasminogen activating enzymes, or it also increases the endometrial vascularity, and there is decreased local platelet count. Also, mechanical damage, local mechanical
What
damage.
are the generations of IUCD? Do all of them cause? In fact, I think you are aware that Mirena, which is a third generation IUCD, has been used for many conditions as a treatment modality, right?
Yes, ma'am.
So is Mirena, or you're talking in terms of copper IUCDs?
Ma'am, mainly the first generation can cause mechanical damage, whereas the third generation
Are
can
we using first generation first generation IUCDs?
replace loop, ma'am.
Are we using? It's obsolete. You only get in X-ray reports and HST to make you like familiar. Like there were these kind of these were used some time ago. You get only for Viva spotters. So
Yes,
no
ma'am.
longer it is used. Okay.
Okay, ma'am.
We still use copper UCDs. So they are likely to cause, at least in the first few months after insertion, women do come with increased menstruation and pain and all that. Okay. Could be
Okay.
due to PID, which is very common first 3 weeks of after insertion. Okay.
Okay.
To ask weight loss.
Ma'am, to rule out any malignant conditions or
Any other causes of weight loss other than malignancy?
tuberculosis,
Anything else?
um, hyperthyroidism.
Is weight loss also can be a problem with AUB? Weight gain.
Yes, ma'am. Then she can have PCOS and
Obesity, PCOS. So
Mhm.
both can lead on to anovulation.
Anovulation. Yes,
And
ma'am.
then they present with typical amenorrhea followed by non-stop bleeding and things like that, right?
Yes, ma'am.
So what is this? Your written history of intermenstrual bleeding. Okay. So what is this intermenstrual bleeding?
Ma'am, bleeding occurring between two menstrual cycles is considered abnormal.
Name some causes.
It can be seen in cervical polyp or any
Can you name some physiological condition? Maybe rarely or sporadically, women get intermenstrual bleeding associated with some kind of crampy pain in the lower abdomen, which happens sometime in mid-cycle. What do you call that as?
Michelma's syndrome.
That is a physiological. Pathological conditions could be sometimes sporadically women may complain, sometimes on and off she cannot correlate with the cycle. That is random, right? Sometimes it can happen on a cyclical basis. So can you name some of those which can happen randomly?
Ma'am,
With some
any
like
polyp,
cervical polyp,
submucous fibroid,
submucous fibroid, okay.
and any cervical erosion, cervical cancer, vulval cancer, or if she has an IUCD insertion. And also decubitus ulcer can also, in a prolapse case, can cause intermenstrual bleeding.
Okay, if at all, what is the type of intermenstrual bleeding which can happen on a cyclical basis? It can happen before periods, it can happen after periods. Have you heard of irregular ripening, irregular shedding?
Yes, ma'am. Ovulatory type of DUB.
We don't, no more we use the terminology DUB. You said DUB or AUB?
AUB now, ma'am.
Yeah, DUB is the terminology we were taught, we were using till recently. It was for AUB, which was with only hormonal imbalance, which used to happen at the extremes of age, and it was the diagnosis of exclusion. When we rule out pregnancy and all other organic conditions, we used to call as DUB. It is no more used, the terminology. Nowadays, we use, for the same condition, we use AUB.
Oh.
Okay, ovulatory dysfunction.
Yes, ma'am.
Right? So, irregular shedding and irregular ripening are types of secretory, rather, it is ovulatory AUB kinds. So, irregular shedding happens, women have her regular cycle, post-menstrual also, she continues to have some kind of spotting and bleeding, and irregular ripening, she will have before her proper flow. This kind of history you will get in many women. She continues to have some spotting, and then she starts getting her cycles because of inadequate progesterone. So luteal phase defects. Okay.
Yes, ma'am.
So the correction would be very easy. If you diagnose, you supplement them with progesterone, they'll get dramatic relief. So what is this history of postcoital bleeding? Why it is important?
Ma'am, mainly to rule out cervical cancer.
Mainly to rule out. Anything else also? It's called as contact bleeding. What you told, those causes of intermenstrual bleeding.
Yes, ma'am.
So like you told, no, so anything over the cervix, ulcer,
Polyp erosion,
any growth on the cervix, polyp, all those can also become a cause of postcoital bleeding. So all this history in general is important to know, but for your case, as for the completion sake, you're taken. So if I ask you to quantify the, like whether this bleeding is heavy, how quantification of the thing is done of heavy bleeding?
The pictorial assessment of blood loss.
Yeah.
If the chart is used, then you give points based on how much of the pad has been used. Where you give 1 point, 10 points, and 20 points, whereas in a tampon you give 1 point. Sorry, ma'am.
Score?
Normally it should be less than 100. Whereas heavy menstrual bleeding is diagnosed if it's more than 200 points.
Okay. You did not ask about tuberculosis, right? Is it important, genital tuberculosis? And you did mention in case of vaginal discharge, how does genital tuberculosis disturb the menstrual pattern? It's very common in India. We have to think of conditions which are very prevalent in our country?
Ma'am, usually at the beginning, there will be heavy menstrual bleeding in genital tuberculosis. Later, when there is adhesion formation, then
Regular endometritis. Okay, later?
because of adhesion formation, there will be decrease in menstruation. There will be oligomenorrhea.
So they'll have oligomenorrhea due to what? How? It heals by cyanic
Five.
inflammation,
Yes,
adhesion
ma'am.
formation, and leads on
Asherman's.
Asherman's, right?
Yes, ma'am.
So they'll have infrequent cycle or hypomenorrhea,
Yes,
and
ma'am.
sometimes they may present you with amenorrhea. That history you should have asked. Okay,
Okay.
so coming back to quantification, you will ask her about and which is the most um, definitive
Ma'am,
method.
the alkaline hematin method.
Is it practical? Though it is most definitive or most practical, it's not very practical to do, right?
Yes, ma'am.
Alkali hematin method, you are right. Next slide. Okay. So you have asked about age of menarche. Is it important to know the age of menarche?
Yes, ma'am. To know the duration of estrogen exposure on the female. Usually,
Per case, is it important?
yes, ma'am. If we are considering fibroid as a diagnosis, then it could be likely because of increased estrogenic state.
Yeah, early menarche to many conditions, not only fibroid, all these hyperestrogenic conditions, adenomyosis, and then fibroid, all these can be a predisposer. But early menarche could be a predisposer. So according to your menstrual history, so did you tell us about that FIGO criteria so for a normal menstrual cycle now?
Yes, ma'am.
The regularity of the cycle?
Should be now it is changed to 7 to 9 days.
7, 8 days. 7 to 9 days if it is within regular cycle. If it is an abnormal cycle, over a period of 12 months observation, right?
Yes, ma'am.
Okay, 20 days, more than 20 days. And then what are the recent terminology, change in the terminologies, right? Can you tell us?
Yes, ma'am.
Like any old timer like me come as your examiner, we still want you to, maybe sometime I'll ask you, if you say heavy menstrual bleeding, I'll ask you what is menorrhagia. So you should know both.
Yes, ma'am. Ma'am, if the frequency of menses is less than 24 days, then the old term for it was polymenorrhea.
Okay.
If it is more than 38 days, then it was called oligomenorrhea.
Okay.
Coming to duration of flow, if it was less than 4.5 days, it was called hypomenorrhea, whereas more than 8 days, it was called menorrhagia.
Okay. What is oligomenorrhea?
Frequency of menses more than 38 days.
38 days, fine. So you have written about LMP, right? What is the importance of knowing LMP?
Ma'am, it is important to know LMP to do any investigations. Like in her case, she's 40 years. She's more than 40 years. So if you want to plan any endometrial biopsy, you should know at what time of cycle she has come.
Okay. In this case, she has a regular cycle. When do you want to call her?
Ma'am, I want to call her in her premenstrual phase before her menstruation starts.
Good. And why do you want to call her only in the pre? She has come at this cycle. Today she has come saying that she had her menstruation 4 days ago. Can she go for DNC or whatever? What do you counsel her? How do you tell her?
Ma'am, I will ask her to come back before her next cycle starts to do an endometrial biopsy.
Okay. I'll come to that later. If any woman has got irregular cycle, you cannot call her premenstrually, then what do you do?
Ma'am, then on the third or fourth day of her menstruation itself,
First day of cycle.
first day of cycle.
And even when you are planning to rule out tubercular endometritis, it is on the first day of cycle when you expect some material and you send for histopathology same day.
Okay.
To rule out tuberculosis, you should always send them endometrium in the normal saline. To rule out for other histopathological examination and reporting, you should send it with formalin. Okay.
Okay, ma'am.
Okay, and the first day. So you said only after 40 it is mandatory. What if a woman is less than 40? She's 30 and bleeding heavily? What are the indications, in other words, to do endometrial sampling, even if she's less than 40 years?
Ma'am, if she has a complaint of heavy menstrual bleeding and it has not stopped even after medications,
Okay.
if her if,
Yeah. And anything else? And if there is a family history of endometrial carcinoma, and if she's not as a high risk case for endometrial CA, like name some predisposing factors or high risk factors for endometrial carcinoma.
multiple sexual partners, lower socioeconomic.
Endometrial carcinoma. I'm not talking of
Oh,
cervix. Are you going to do endometrial biopsy for CA cervix? Are you going
no, ma'am.
then?
Uh, I'll tell risk factors for endometrial carcinoma.
So what I mean to say, if there are any risk factors, like she's obese, she's a case of PCOS, okay?
Nulliparity.
Nulliparity, yes. So all these conditions, and she has got endometrial thickness. What is the endometrial thickness? A normal thickness cutoff beyond which you think of doing an endometrial sampling, even if she's less than 40.
Ma'am, in pre-menopausal women, it is if it's more than 12 mm.
Yeah, more than 12 mm. Postmenopause?
More than 4 mm, you will consider to do.
Okay, so you'll have to, where else this LMP becomes important? In gynecological practice. In obstetric, you all know that it is only for important to calculate expected date of
Yes,
delivery.
ma'am.
In gynecology, you need this information in a lot more conditions, like name some. One you told is to time her endometrial sampling. What if she wants to have contraception? You'll have to plan and give her either OCPs or IUCD insertion, whatever have to be done within first 5 days. If she wants to conceive, then also we want to start the treatment within first 5 days, 2 to 5 days. You start in giving induction of ovulation, and you want to do investigation for tubal patency. When do you do HSG or diagnostic histrolab? Do you do post-menstrual or premenstrual?
Post-menstrual, ma'am.
Within first 10 days, you plan all this. Okay, so for so many things, you need LMP, information on LMP in gynecology. Okay. Next, next slide. Go to the next slide.
Yes, ma'am.
Okay, obstetric history. She's para 4. So is there any indicator in this slide towards your diagnosis?
Ma'am, since she's
How
para
does this differentiate your a provisional diagnosis as fibroid or
ma'am, this is helping me think that it is adenomyosis because of her being multiparity, P4, whereas fibroids are mainly seen in nulliparity.
Okay, when was her last child? You did not mention, I suppose.
Yes, ma'am.
You are supposed to know her last child, and all are doing healthy. Okay,
Yes,
fine. And again, no history of IUCD insertion and usage of OCPs. Okay, having said that, she has not undergone sterilization. And okay, if she has undergone sterilization and come back to you saying that she has got some menstrual problems, kind of dysmenorrhea and menorrhagia, what is that condition called as? We do often come across, they clearly tell that following sterilization, her menstruation has become heavy and kind of dysmenorrhea. It is called as post-ligation syndrome. So it happens in vasectomy patients also. They do come across pain in the scrotum and things like that, because we deal with these female patients. They say that they have this problem of menorrhagia and dysmenorrhea following sterilization. They were fine before the procedure. So that is because of the disturbance in vascular supply. We ligate, no, the mesosalpinx and pelvic congestion following that. Okay, that is one syndrome, post-ligation syndrome. And if at all she is not using any contraception, she'll ask you for a contraception advice. She is para-4 leaving 44 years, and she's not sterilized. And she's got heavy menstrual bleeding and dysmenorrhea. Which is the ideal contraceptive you would advise her?
Ma'am, Mirena, ma'am.
Very good. Okay, you would advise Mirena. Why? How it is going to help her out?
Ma'am, it causes endometrial atrophy, where she'll be able to regularize her cycles and also get contraceptive benefit.
Regularize, no. She may not have that benefit of regularizing. In fact, they'll have initial 2 to 3 months irregular bleeding, spotting, which is going to be troublesome. You have to counsel them. And later they may have lesser and lesser bleeding, and eventually they may go for amenorrhea. That history, that the counseling part you have to do. So it's nothing to do with regularization of the cycle. At 44 years, this will take care of her menstrual problems, as well as if at all she goes for any vasomotor problems like vasomotor symptoms or postmenopausal HRT is advisable. It is valid for how many years? It's the Mirena is valid for how many years?
5
5
years.
years, right? She's 44 now. So she attains menopause. What is the normal age of menopause in India?
55 years now.
55 years. What is the normal age of menarche in India now?
10 to 15
Why?
years.
It's not all cases. I think average is 52. Some may go until 55, but 51 to 52, 51.5. So it is getting prolonged. So in case like she keeps Mirena and she develops some vasomotor symptoms, for which usually we prefer to give her some estrogen therapy, then that unopposed estrogen action will not be there, because already there is one Mirena kept inside to take care of her counterpart estrogen unopposed action. So you can be relieved, you can be tension free to give her any estrogen preparations which is suitable for her. Would you like to give OCPs at 44 years? Definitely no, right? So
Yes.
it's not advisable after 40, at least in our country,
Yes,
because
ma'am.
of the associated complications.
Yes,
So
ma'am.
we're not going to discuss about that, because we have many more things to discuss pertaining to our case. Okay.
Yes, ma'am.
Okay, next. Next slide. What medical interventions you meant?
Ma'am, if she's taken any drugs for the same
For the same
complaint.
condition, right?
Yes,
So
ma'am.
did you ask her that she had, for the last 8 months she's in with this problem? Did you ask her that she had been to any other doctor or a local? They usually go to the local doctors for the same complaint. Has she taken any medication? You said did not relieved by, I think in your history,
Yes, ma'am. Not relieved on
not
medication.
relieved by medication. So
Yes.
that history you have elicited, right?
Yes, ma'am.
You should go to the doctor and took some medications. What surgeries you meant?
Ma'am, if she's undergone any myomectomy, then the diagnosis can go towards fibroid if she's already had a previous myomectomy.
Myomectomy or DNC or hysteroscopy. Okay. And tuberculosis, you know how it is going to disturb. Thyroid disorders, how do thyroid disorders affect menstrual function? Menstrual
Ma'am, in hypothyroidism, they have 30 to 50% chance of having any menstrual disturbance because of increase in TRH, which interferes with the normal physiological pulsatile GnRH secretion. So there is decreased clearance of
It
estrogen.
is most common, like close to us, like most accepted theory of disturbed menstruation because of thyroid problems.
Hypothyroidism.
Okay, how does it affect? What is the mechanism behind? Is there a relation between FSH and TSH? How are they related?
Yes, ma'am. Both of them are
Similarity in alpha chain.
yeah, they share the common subunit of alpha chain.
Yeah, alpha chain is same. HCG, FSH, LH.
Yes, ma'am.
Because of that, when TSH is high, competitively inhibits.
FSH
So there will be
decrease.
ovulation.
Yes, ma'am.
Ovulation is disturbed. So they will have menorrhagia, anovulatory cycles and menorrhagia. And because the basal metabolic rate is so low with hypothyroid patients, they put on weight. And obesity in turn causes
Peripheral conversion of fat to
right? Hyperestrogenism and ovulation. This is a vicious circle. It goes on. So why did you ask blood transfusion in the past?
if her heavy menstrual bleeding has been so severe that she required blood.
Okay. Okay, she did not.
No, ma'am.
What if she refuses blood? What other choice you have? She did not take anything before. Now she has come to you. She's pale.
Iron supplementation,
And in the form of?
IV, intravenous.
Okay. Good. At least you are aware of that. Ferric carboxymaltose.
Yes,
Or what is autotransfusion? So there is always a possibility that she can opt for autotransfusion or she can opt for IV parenteral injections. Okay, what is it? Similar complaints in the family. What similar complaints you are keeping in mind?
ma'am, in cases of fibroid, it usually is also seen in her mother or sister. So diagnosis could go towards fibroid if there were similar complaints.
What about PCOS? Is there a family history?
Yes, ma'am. PCOS also is commonly seen in the families.
Okay. Bleeding disorders again. And then, okay. Why did you ask about cancer syndromes in the family? Can you name some of these cancer syndromes?
Ma'am, Lynch syndrome and hereditary
Lynch 1 or Lynch 2?
Lynch 2.
Okay.
Then,
In relation to your AUB you're talking.
yes, ma'am.
Anything else you know?
Hereditary ovarian and breast cancer.
Yeah, BRCA mutations 1 and 2. And then Lynch 2. Lynch 2, components of Lynch 2.
Colorectal cancer,
Mm.
endometrial cancer,
Mm. And ovarian or breast. Which cancer?
ovarian cancer.
So if at all they have you come across this family history, in what way it's going to change your management?
Ma'am, if any cancer syndromes are there, then instead of doing hysterectomy, you can also remove the fallopian tubes and the ovaries to decrease the risk of cancer in the patient.
In an early age, you may have to resort to do hysterectomy and oophorectomy and salpingectomy. What is the place of doing salpingectomy? I will come to that little later. So now, instead of doing only salpingectomy, either way we are doing for all those who have completed their family. We are taking for any other benign condition like fibroid uterus, doing hysterectomy. We are doing salpingectomy also along with hysterectomy because it has no role after completed family. Okay, other than fertility, we don't consider anything else is important to keep the tubes. So that is because it is the nidus of stick cells. What is stick cell theory?
I'm not sure, ma'am.
So serous intraepithelial tumor cells in the fallopian tubes that can become a nidus source for serous high-grade serous epithelial tumors in the ovary. So that continuity of the tube which goes and embraces the ovary will pour these cells onto the ovary surface of the ovary, which becomes a high-grade surface epithelial tumor. That is the funda we are going to. Even that for that matter, even discontinue the continuity of the tube in terms of you do only sterilization, ligation of the tube, where you're going to block the continuity and the passage of the cells. That also will give protection. It is one of the protective factors for ovarian cancers. That is the concept of stick cell theory, where we are practicing salpingectomy rather than oophorectomy. So with this history of cancer syndromes, we may have to do early oophorectomy to prevent ovarian cancers, right?
Yes, ma'am.
So along with hysterectomy. Okay, next slide. So mixed diet, appetite, normal, disturbed sleep. Okay, no history of contraceptive. You're not asked anything. It's not very uncommon to see our ladies now smoking and alcohol and drugs and all that.
Yes, ma'am.
Should you ask multiple sexual partners and all that? Pertaining to the case, if at all she had come to me with a history suggestive of CS cervix kind of discharge and bleeding, I would have asked multiple sexual partners, but history of smoking, alcohol is not very uncommon these days, right?
Yes,
Drug
ma'am.
abuse.
Yes, ma'am.
Does smoking affect menstrual pattern?
Yes, ma'am. It is actually a protective factor when it comes to any estrogenic hyperestrogenic states like fibroid or endometrial carcinoma, endometrial hyperplasia.
So would you advise her to smoke
No, ma'am.
to get to protect? So though it is protective, it has its own set of complications. So, but in history, you're supposed to mention all that, right? Next slide. What is the role of diet? Role of diet?
Uh, Ma'am, if she's
Red
having
meat, white
like
meat, anything
any
like that
endocrine
is correlated with the fibroid or adenomyosis pertaining to your case.
no, ma'am.
There is correlation. Meat eaters are likely to have more. Okay, on examination.
Patient is conscious, cooperative, and well oriented to time, place, and person. She is moderately built and well
What
nourished.
is so built or
Ma'am,
BMI otherwise?
built can tell if she is hyperthyroid or hypothyroid, which are again causes of AUB.
So she's BMI is 28.7. What is the normal BMI? No.
18.5 to 25, ma'am.
Yeah, it has come down to 23, no? But for your undergraduate level, okay, if you say that. But what is the importance of BMI?
Ma'am, again, if she's
Patient
overweight,
normal.
obese, she can have PCOS or anovulation is more common in.
And it is advisable to see any of these problems, even metabolic syndromes, menstrual, whatever, we advise them to follow optimal weight and lifestyle modifications to have an optimal weight, because it is very important to maintain the optimal weight for their age, that is BMI. Okay, so if that is very important, because even when they attain menarche, so these days you see there is a change in the trend of attaining early menarche and late menopause because of many reasons. One could be due to because of their obesity. The estrogen is high and they continue to have these and to even attain menarche at certain age, you need some amount of fat. Those who are athletes and they don't have fat, size 0, they will have amenorrhea because of anxiety, stress, and no fat in the body. So that some amount of fat is important. Some normal BMI is important to have their menstruation. Even when when the girls come with primary amenorrhea, define primary amenorrhea. You are aware of it, Pranjal?
Yes, ma'am. If she has not attained if the secondary sexual characters are not attained before 8 years and menstruation before 9 years.
No. With the development of secondary sexual characters, age is 13 cutoff, and in the absence of that, it is 15 years. So, despite all that, she's not attained marriage. First thing I would like to look is her build and her BMI and her fat level. Some amount of fat is very, very important to attain menarche, or the maintenance BMI is very, very important. Okay, pallor present. So mild, moderate degree, because she's been bleeding for 8 months. Okay, and then thyroid is normal. Okay, so you know how thyroid affects. Fine.
Yes,
So what's
ma'am.
the importance of breast examination in a gynec patient? Obstetric, yes, you would like to look for nipples, say whether it is inverted, whether it is retracted on in a gynec patient. It's mandatory. Gynec and obstetric thyroid and breast examination is mandatory. In obstetric patient, you have to add on height, weight, and gait. Gait is one thing which is missing here. Here you're writing height, weight. Gait is one thing. Gait also you should add up in obstetric case. Okay, right. Examination of breast. Is it important? It could be, if at all you are dealing with a case of mass per abdomen. How important?
Again, any cancer syndromes pertaining to both BRCA mutations, breast and
Could be
ovaries.
primary or secondary breast cancer. Okay, from here it may go to the ovary, or from ovary it may come to the breast. So it could be a primary growth or secondary growth. You should always make it a habit to examine breast. Okay, next. Next slide.
Vitals, pulse rate 72 beats per minute, blood pressure 130 over 80 mmHg, respiratory rate 14 cycles per minute, which is thoraco-abdominal type, and temperature is afebrile.
Okay.
Coming to systemic examination, cardiovascular system, S1, S2 sounds heard, no murmurs heard. Respiratory system, normal vesicular sounds heard and no added sounds.
Okay.
Abdominal examination, inspection, shape of the abdomen is flat, position of umbilicus is central and inverted, corresponding areas move equally with respiration.
What areas you looked for? What are the quadrants of abdomen?
Ma'am, there are 9 quadrants of the abdomen.
Okay.
Stria gravidarum present, no scars, sinuses, or dilated veins or pulsation seen, and the hernial orifices are intact.
What hernial orifices you looked for?
If she's undergone any previous surgeries or anything.
You mentioned hernial orifices.
Umbilical hernia.
Or any surgery that you call as incisional hernia. She has not undergone even tubectomy, right?
Yes, ma'am.
No history of any surgical interventions, you said.
Yes, ma'am.
Is there any femoral hernia? Is there any inguinal hernia? What you meant? Next slide.
Palpation, abdomen is soft and no organomegaly.
Okay. What organomegaly meant?
Ma'am, if the uterus is enlarged and is palpated per abdomen, or any free fluid or anything.
Okay, what are it's an abdominal palpation, right? What are the causes for mass per abdomen? Gynecological causes and non-gyn. What are all the things you looked for?
Ma'am, if she has a fibroid uterus or any ovarian tumor causing mass per abdomen.
In your case, you would look for what are the things? You say heavy menstrual bleeding with dysmenorrhea. What are the things you look for? One is
Fibroid
uterus and
There is ovarian masses.
Ovarian tumor. Which type of, do all ovarian tumors give rise to menstrual abnormalities?
No, ma'am. Only estrogen producing tumors like granulosa cell tumor and theca cell tumor.
Okay. Okay, anything else you can look for? Can adenomyosis be palpable?
Usually not, ma'am, because it is not more than 12 to 14 weeks uterus size.
Though, but rarely, of late, we have been seeing bigger adenomyosis cases, more so of adenomyoma. What is adenomyoma?
Focal adenomyosis.
Yeah, we do come across. So for your UG level, maybe you can say it is usually disease confined to 12 to 14 weeks. Even 14 weeks can be palpable, right? So just the superior border you can palpate. Okay.
Yes, ma'am.
What are the other organomegalies you can come across on abdominal examination other than this?
Hepatomegaly,
The organs are
splenomegaly.
there.
Yes, ma'am. Hepatomegaly, splenomegaly.
Okay. Yeah, surgical causes.
I don't know.
Obstetric causes. When we ask you to write about DDs for mass per abdomen, you have a whole list starting from full bladder, pregnancy, and appendicular mass. All that you write, no?
Yes, ma'am.
Sheath hematoma. You should keep all that in mind when you are examining. Pertaining to your case, you have only 2, 3. So if at all there is, you don't you look for any free fluid, maybe ascites is there. So that also can give rise to kind of distension in the abdomen. Encysted ascites may present as mass kind of thing. So if there is ascites or free fluid in the abdomen, what are the causes you think of?
Again, fibroid uterus and any ovarian mass both can cause free fluid in the abdomen.
Which type of fibroid?
Submucous fibroid.
I'm talking of free fluid in the abdominal cavity. Submucous, where is the location of the fibroid?
Yes, subserosal fibroid.
Yeah, subserosal pedunculated. So what is, in other words, can you explain to me what is Meek syndrome and what is pseudo-Meek syndrome? We are talking in terms of ovarian tumors and fibroid, which are solid tumors. These are the ones which are likely to irritate the peritoneum and cause free fluid, right?
Yes, ma'am. Meek syndrome is seen in ovarian masses like fibroma, thecoma, Brenner's tumor, and granulosa cell tumor, where there is right-sided pleural effusion and ascites. Whereas any other cause like uterine fibroids,
Only ovarian fibroma. Anything else, Brenner and things like that goes in favor of
pseudo-Meek syndrome.
okay, right-sided. So if there is free fluid, you should always think of with a benign lesion, kind of this with and a solid mass. Okay,
Okay.
you should always think of Meeks and pseudo-Meek syndrome. Okay, next slide. So how do you, if at all, if it is fibroid, describe the features of fibroid and palpation or inspection?
Ma'am, on inspection, if it is more than 12 to 14 weeks size, then it all the borders can be.
Is it only restricted to be 14 to say 12 to 14 weeks? It can be of any size. It may extend even up to xiphisternum. You have seen such big fibroids, you know. It's not necessarily going to be 14 or 16. So what will be the consistency and the mobility? Describe all that.
Ma'am, it will be solid in consistency, and
We don't call it a solid or is it firm or hard or soft?
it is firm in consistency.
What about the normal uterus? Is it firm or soft?
Firm, ma'am.
It's also firm. So how do you know that which is firm? So they always compare, you know, tip of the nose. It's supposed to be the normal consistency of the uterus. And a fibroid is going to be harder, means firmer than the normal uterus. And adenomyosis is softer than the
Softer. Yes, ma'am.
softer than the normal uterus. So that is kind of lip. They compare to the consistency of the lip. That is how they compare when they have to compare both. So that is going to be firmer than the normal uterus. And then mobility.
Yes, ma'am. There is side-to-side mobility is seen.
Okay. Anything else?
Like if it has any long pedicle upward and downward of
Write in your DAS, no, surgical, this one manual. How do they describe a mass? Site, size, and then surface. You should tell all that.
Okay.
Oh, what would be the size? You said it is variable, right? Size is variable. Site.
It could be present anywhere between the ziphistine.
By default, what is the location of the fibroid? Where do you commonly see fibroid?
Submucosal.
No, not in the uterus. I'm telling in the abdominal cavity.
Suprapubic region.
So any mass arising from the uterus is likely to occupy the midline. From this suprapubic region, it grows upwards. So a mass which is occupying the midline. So we usually think in terms of fibroid. Exception to the rule are a subserous fibroid, which is lateral, a parasitic fibroid, which is occupied anywhere else.
Yes.
Okay. Similarly, what is the location of an ovarian tumor by default? Because the adnexite is arising from the adnexite which is in the
Right to left iliac fossa.
iliac fossa. So they usually occupy right or left iliac fossa. When can a ovarian mass can occupy the midline also?
Yes, ma'am.
Like in what condition? When it is pedunculated. Give an example. Common ovarian tumor which is pedunculated comes and occupies and sits anterior to the uterus.
Not sure.
Common during pregnancy. Others also can answer. Anyone else? Dermoid. Okay, dermoid tumor, dermoid cyst, which is very common during a pregnancy, can occupy the midline. Understand? Any pedunculated ovarian mass can occupy the midline instead of being in the iliac fossa. Okay.
Okay, ma'am.
Next is
Auscultation. Bowel sounds are heard.
Hmm.
Coming to local examination, the vulva appears to be normal.
So anything else, what you can expect in the vulva, which can be a cause for abnormal bleeding, maybe in terms of spotting or whatever. What pathologies in the vulva can give rise to abnormal menstruation, abnormal bleeding pattern?
Any vulval ulcer.
Okay. Urethral caruncle, very common during postmenopausal age group. They may come with hematuria or they may come with dysuria, sometimes spotting, and any vulval varicosities when they undergo ulceration. And sometimes they don't know whether they're bleeding from hemorrhoid or bleeding from the vagina. So bleeding hemorrhoids, anal fissures. After the act of defecation, they may see some blood-stained clothes and they say that it is bleeding from vagina. Anything else? And as we already discussed, a prolapse, which is lying out. So uterovaginal prolapse, which is lying outside the introitus, can be with the decubitus ulcer, can be a cause of abnormal uterine in terms of spotting, maybe spotting an anand of irregular strains. Okay.
Okay, ma'am.
So did you take pap smear? Why did take pap smear? She was not bleeding, no? When was her LMP?
On 12th of October.
When you examined her?
No, she was not bleeding during the time of
Why did you
examination.
take both? Why did you take both the dates? Date
Ma'am,
of admission and date of examination.
ma'am, because of to understand the timeline and progression of the illness. So when the patient was admitted, it provides a reference point to track her progression, her symptoms, and her response to if any treatment was given to assess the severity and urgency of treating her as well.
Maybe she will not be the same when she came with your treatment. She would be better now. You understand? So she came with acute pain or acute bleeding, and now with her treatment, she's settled. So it will give you an idea of how she is doing good with the treatment. So always it is a good practice to take date of admission and date of examination. And when you examined, she was not having bleeding, right? So when you take that pap smear when she's not bleeding, what type of pap smear is that?
Wow.
Why do we take, by the way, why should we take pap smear?
For screening for cancer cervix.
Is it mandatory?
Yes, ma'am.
Patient refuses. Even then, if she refuses, we cannot force her. It is her wish, but we should always make them understand that this is the most common and a preventable cancer, you know. So there is so much time after the detection by pap smear or in terms of CIN. What is CIN? Early carcinoma, cervical intraepithelial neoplasia. Okay, that is in the early stages. If you detect there is so much latent periods, 10 to 15 years she will have, where we can do a lot of things to prevent her going to invasive cancer and dying because of cancer, right? So it is Government of India guideline to do an opportunistic screening or in fact an universal screening for all women. If not possible to screen all, at least an opportunity when you see and for other gynec conditions like this, bleeding or any other, you're expected to take a pap smear. What are the methods of taking a pap smear? One is conventional, like what we have. Have you seen in gynec OPD?
Yes, ma'am.
We have an IS spatula and a cytobrush.
Yes,
You
ma'am.
put it, cytobrush will go inside the endocervical cavity, and then you take an IS spatula, we fit into the ectocervix and we rotate 360-degree, put the spear on the glass slide and say,
95% ethanol, it is fixed.
that is one method. What is liquid-based cytology technique?
Ma'am, the cells are scraped using a special broom and collected in a liquid medium. And it is transported to the lab, and like other blood and other cells are removed.
Yeah, that is why I asked. She was not, even if she had a little bit of bleeding or some mucosal discharge, that will be dissolved and that will be taken care by the media which is there in the liquid-based cytology. And all those will be lysed and you get the clear cells, you supernatant liquid and the cells which are sediment. When you filter them, you will get a very beautiful slide which is not smudged like a conventional smear. So that has got a lot of advantages of quality and the reporting. So wherever possible, and it helps for even a simultaneous test of which DNA, which virus,
HPV.
HPV virus. You can detect HPV DNA also with the same sample. So it serves the dual purpose. So as if whenever possible, try and do liquid-based cytology. Okay, so you're taken pap smear. Good. Then next slide. When do you stop? 44 years you expected. When do we stop? Starting age and ending age. Can you tell me? For undergraduate level, it is from 21 years to 65 years. Okay.
Okay.
Next.
Coming to bimanual examination findings, the uterus appears to be symmetrically enlarged to about 12 week size, and the uterus is found to be mobile, anteverted, symmetrically enlarged, and soft in consistency.
So what does it suggest? Appears to be symmetrically enlarged.
Ma'am, usually in fibroids, it's asymmetrically enlarged, and in adenomyosis,
Is there any exception to this rule? Asymmetrically enlarged. What if it is a submucous fibroid? and not bosylating the surface of the uterus. Then also you may get a symmetrical enlargement, and you may not be getting that firmer thing because it is hidden inside the mucosa, inside the cavity. So there is always a DD. It's a differential diagnosis to give. It could be a submucous fibroid. It could be what? Symmetrically enlarged, 12-week size,
Adenomyosis.
soft, and what else you missed? Adenomyosis, how it will be on palpation? Is it going to be tender, non-tender?
It could be tender, ma'am. Adenomyosis.
So the times it is tender on palpation. So what is it is characteristically these findings are described by whom? Any name? It's described by Halban. It's called as Halban's sign when you get these findings, no?
Yes, ma'am.
So Halban is the one who describes.
Albus tenderness. Yes, ma'am.
Yeah. So your DD on examination at the end of your history taking and examination. Next slide. Do you have anything to show?
Yes, ma'am. Summary. 44-year-old para-4 living for female came with heavy menstrual bleeding and severe congestive dysmenorrhea since
You did not comment about adnexa, I think, no? Only you look at the uterus and stop by. Did you do bimanual examination by the way, or anybody else gave you the finding?
No, ma'am, I didn't do. Staff had done.
So did they not comment about the adnexa? You are supposed to comment about the adnexa. Because your DD is still one more thing, not only fibroid and adenomyosis. You are thinking in terms of ovarian mass also, right? Ovarian tumor, which is hormone secreting.
Yes.
So you have to look into the adnexa. And if you are thinking in terms of adenomyosis, you are supposed to feel for the pouch of Douglas also. What do you see? What do you get in adenomyosis? In cases of if you think in terms of adenomyosis, routinely we do palpate all these, we go to the either adnexa and palpate if there is anything palpable. In case of CS cervix, we try to look for any adnexal induration. And in case of ovarian enlargement, in case of PID, what do you get in PID? PID is always,
Cervical motion tenderness.
after the pregnancy, infection is the most common cause of abnormal uterine bleeding still in India. So being the second most common, I always try to look for tubo-ovarian masses, right?
Yes, ma'am.
Secondary to infection, PID. Okay, and then I look for ovarian tumors. And I come down and look for pouch of Douglas. In pouch of Douglas, if I find anything, nodularity, maybe.
It can suggest of any ovarian malignancy.
Yeah. Endometriosis.
Again, it might be felt. Nodules might be felt.
Is it significant if you find endometriosis and your clinical diagnosis is still adenomyosis? How will you correlate?
Ma'am, adenomyosis can coexist with stuff.
Is adenomyosis, endometriosis, and fibroid. They say in joke, they always say adenomyosis is paternal uncle is fibroid and maternal uncle is endometriosis.
Yes, ma'am, it can coexist in many conditions.
Yeah, so if your clinical diagnosis is adenomyosis and you still feel there are nodularity, cobblestone appearance, or feel in the pouch of Douglas, that goes in favor of endometriosis because the most often they coexist. These are all hyperestrogenic states, right?
Yes, ma'am.
So you should always make it a habit, or if you're not given, you should ask, what was the finding?
Okay.
Next.
Summary. 44-year-old para-4 living for female came with heavy menstrual bleeding and severe congestive dysmenorrhea since 8 months. On examination, she has moderate pallor, symmetrically enlarged globular 12-week uterus size was seen, which was mobile and antiverted. So this is a case of abnormal uterine bleeding, likely due to adenomyosis, which is AUB-A.
Okay, this is according your provisional diagnosis is AUB-A. What is AUB-A? Which classification is this?
Ma'am, this comes under palm coin classification.
Given by a well-known body like FIGO.
Yes, ma'am. Figo.
Yeah. What are the divisions? What are the
Ma'am, the functional,
combined?
the structural causes are due to polyp, P is palm, P is polyp, A is adenomyosis, L is leiomyoma, and M is any malignancy. And COIN is non-structural or functional causes, where C is coagulopathy, O is any ovulatory dysfunction, E is any endometrial dysfunction, I is iatrogenic, and N is not otherwise classified.
What is FIGO?
Federation of International Gynecologists.
The National Federation of Obstetrics and Gynecology and Obstetrics. Okay, they have classified into structural and non-structural causes. Your provisional or probable diagnosis is AUB, but you are not sure your history and examination, but still you have to confirm with your. So at the end of history, you will reach some diagnosis. At the end of examination, you reached, and you will confirm with your investigation. They should go in sequence.
Yes, ma'am.
Your investigations should confirm your diagnosis. So now, before you proceed, how do you confirm your diagnosis?
Ma'am, by investigations, USG.
Before you confirm, yeah, side by side, you will send her for the USG. Anything else, because she's bleeding. She is 8 months bleeding history, and her hemoglobin is moderate pallor. Any other investigation you would like to start with?
CBC,
Okay.
where RBC
There was
is
previous history of amenorrhea. I would have said, okay, do UPT in all cases, and then CBC. Okay. In CBC, what are the things you look for?
ma'am, her hemoglobin percentage, since
And
she has pallor,
okay.
and WBCs to rule out any infections like PID, and platelet count is important.
You said leukocyte sometime.
Yes, ma'am.
And platelet for?
To rule out any bleeding disorders, clotting disorders, and leukemias or any malignancies like that.
And then what else you look for?
You can also do bleeding time, clotting time,
Okay.
prothrombin time.
Which is more specific, is bleeding, clotting, or PT and APTT?
PT and APTT.
So when you're suspecting seriously in a younger girl, in adolescent girl, definitely we are going to go for PT, APTT rather than BTCT, right?
Yes, ma'am.
Then what other investigations you do?
Then I would want to do a thyroid profile in her case.
Okay.
To diagnose any undiagnosed hypothyroidism or hyperthyroidism.
Okay.
Then we can also do serology.
Okay. Serology for what?
In case you want to intervene or operate, serology, LFT and RFT should be done.
Liver?
Yes, ma'am. LFT, liver function test, should also be performed. Also because it to rule out any.
Serology. What is the correlation of serology with the liver? HBsAg,
Yes, ma'am.
cirrhosis, and bleeding problems, right?
Yes, ma'am.
Okay, any other investigation you would like to do?
Ultrasonography. Transabdominal sonography can be done.
Do you want to do transvaginal or transabdominal? In your case, what was the size of the uterus?
12-week size, ma'am.
12 weeks. Which is the preferred route of ultrasonography?
Preferred will be transabdominal sonography.
Okay, why? Transabdominal is preferred.
Again, yeah, because you can check for any fluid in the abdomen or any adnexal mass is better visualized in transabdominal.
Yeah, but generally, when the uterus is less than 12 weeks, and it is better to do a transvaginal scan where you can look for what are the structures, what are the things you can look better with the transvaginal probe. Endometrial thickness, and then
Endometrial cavity, the uterine size.
submucous fibroids.
The probe is closer in a TBS examination.
Adnexal pathology, if it is smaller, lesser than 12 weeks, transvaginal is preferable than transabdominal. We prefer transabdominal in case of bigger uterine masses like fibroid. So where transvaginal probe cannot reach and delineate all the details. So when I'm doing a abdominal scan, other than uterus, what else? It's a big uterus, not your 12-week size uterus, maybe 20 weeks. What other things, or 24 weeks? What other things you would like to look for?
Even any fluid in the pouch of Douglas or any pressure effects of fibroid can also be looked
Like pressure effects where? On what?
on the bladder or the
Is it on the bladder? 12 weeks more big size, I said. Lateral towards the broad, iliac fossa and above. What is the pressure? Can pressure on the ureter cause something?
hydronephrosis.
Kidneys and ureter.
Hydronephrosis.
Rule out hydroureter nephrosis. Otherwise, if you're not looked for it and not documented, later post-surgery or post-treatment, you happen to come across in a subsequent scan, you're going to face litigation problems. You should always be alert, cautious, and mindful about looking for any hydroureter nephrosis if it is a big uterus, big fibroid, or any mass which is above the level of the symphysis pubis, more than 12 week size. Okay.
Okay, ma'am.
That is your advantage, and you have to look for spleen, you have to look for liver, because you are thinking in terms of cirrhosis, you're thinking in terms of leukemia. So all those things can affect liver and spleen size, right?
Yes, ma'am.
You should take a good survey of all the abdominal organs, including liver, spleen, and kidney. Not only the uterus. Okay.
Okay, ma'am.
Okay. Anything else? Only scan you do. Anything else will help you to see whether it is a ovarian mass. If it's a ovarian mass, anything else you do?
Doppler.
Yeah, good. Doppler. What is the indication for doing Doppler? What are the indications?
Ma'am, in polyps, you can do a Doppler.
No. Yeah, maybe you see the feeding vessel. Good. Then what else? In case of fibroid, how do you differentiate between a fibroid and adenomyosis? By applying a Doppler, by putting a Doppler, how does the bleeding pattern or how does the vascular pattern look like?
Ma'am, in fibroid, there's a pseudocapsule and the blood vessels are surrounding the fibroid.
Okay.
Or in any type of subserosal fibroid, you can see a bridging vessel sign.
So they'll be coming from the periphery. As they reach center, you will not see that uptake. So if at all, more so if they've undergone degeneration. But that pattern you will not see. So it may be erratic in case of adenomyosis. Okay, Doppler is always an additional information which you have to see. So in case of fibroid, if you're doing a scan, what information you're going to get? Endometrial thickness, you will see, I said, and the cutoff endometrium, I think you told me less than 12 and more, less than 4. It should be depending on the reproductive age group or postmenopause, right?
Yes, ma'am.
So you will look for submucosal fibroid, you look for polyps, and then what is fibroid mapping?
Ma'am, usually done as a transvaginal scan to locate the fibroid. And
Not necessarily transvaginal. I said, what if it is a big one?
okay, ma'am. Then you should do transvaginal.
Your root depends on the size of the uterus, right?
To know the exact location, size, number of the fibroids.
Number, size, location, all that you're going to name them. So that is fibroid mapping. It is important if at all you are taking her for any myomectomy. So you should not leave back some fibroids and later they grow. All that is very important. That is called as fibroid mapping. According to FIGO, what is the mapping like? How do you classify fibroids? 0 to what is the grades given?
Ma'am, 0 to 6.
8. Anyone else also can answer. Dr. Divya, anybody on chat box answering? Dr. Divya, you are there? Hello? Only Pranjal need not answer all the questions. She is doing a very good job, but others also can answer.
Ma'am, type 0, type 1, and type 2 is a submucosal type of fibroid.
Okay.
Type 0 is fibroid which is entirely in the uterine cavity. Type 1 is when more than 50% is in the uterine cavity. And type 2 is when more than 50% is intramural. Whereas type 3 and type 4 are types of intramural fibroids, where type 3's fibroid is 100% in the intramural, except for if the edges is touching the endometrium. And type 4 is fibroid is 100% intramural and the edges are not touching the endometrium. Type 5, type 6 and type
What is
7.
hybrid variety? Hybrid leiomyoma?
Ma'am, where it could be either submucosal and intramural, both types of fibroid.
What is a broad ligament fibroid?
Ma'am, it can be true and pseudo broad ligament fibroid. If it is arising from the broad ligament, then it is a true broad ligament fibroid. Whereas a subserosal fibroid that is coming onto the broad ligament is a pseudo broad ligament
How do you
fibroid.
differentiate what anatomical structures will differentiate between true and false broad ligament fibroid?
Ma'am, the ureter, if it is medial to the ureter, then it is a subserosal or a pseudo broad ligament fibroid. If it is lateral,
Pranjal, again, come again.
ma'am, if the fibroid is medial to the ureter, then it is probably a pseudo broad ligament fibroid.
Fibroid is medial to ureter. You mean the ureter is lateral?
Yes,
Then,
ma'am.
okay.
Yes, ma'am.
Yeah. So that is about fibroid. What is hybrid leiomyoma? Which is intramural and it touches everywhere. It touches the endometrium also. It grows subserosally, all the 3 layers. That is hybrid.
Okay.
Okay. So what is the role of MRI? Is there a place for MRI?
Ma'am, in case of adenomyosis, it is actually the investigation of choice.
When you have a doubt, by history and examination and ultrasonogram confirms, and there is no need in our country, at least when things are costly. So when it is in doubt, you may have to go for a definitive diagnosis or the gold standard, whatever. It is MRI. So can you describe the ultrasound features of fibroid and adenomyosis? How do you differentiate them?
Ma'am, in fibroid, the USG findings will be that it is well defined and it is a rounded tumor and it has hypoechoic with cystic spaces if there is any degeneration. And if it is an intramural type, then it is centrally located with homogeneous appearance. Whereas in adenomyosis, there is diffuse growth and enlargement is mainly on the posterior wall. Here in adenomyosis, it has a heterogeneous type of appearance. It is also called a salt and pepper appearance. It can have any subendometrial cystic lesions can be present. And endomyometrial junction is not well defined in case of adenomyosis. It can be even thickened for more than 12 millimeter. And it has a typical Venetian blind appearance because of echogenic striations that are present.
Okay.
Yes, ma'am.
Island, cysts, Venetian blind, and is there any asymmetry in the walls of the uterus?
Yes, ma'am. Posterior wall is more thickened in adenomyosis.
Right, and the size usually will not be bigger than 12 weeks or usually, but there are always exceptions to the rule. Okay, this is how you differentiate. And what next? She's a 44-year-old woman and she has history of abnormal uterine bleeding. What other investigation you would like to do? After your blood investigations, after your scans or MRI, whatever, it confirms that it is adenomyosis, and then what else you would like to do?
Ma'am, since she is more than 40 years, endometrial sampling is important in her case.
Very good. So she's more than 40. How do you time endometrium? I think we discussed, right, when we talked about LMP. So what are the methods to do endometrial sampling?
Ma'am, either an endometrial biopsy or endometrial aspiration cytology can be done.
How do we do these days?
Ma'am, these days it's an OPD procedure which is done without any anesthesia.
Previously, we were doing D&C. So we were dilating and curating. So these days we use Pipple, which is less than 4 mm in size, which could be just an office procedure. She need not stay in hospital. It is painless. It's a daycare procedure, you know. You can do and send her home the same day. And the sensitivity and specificity are as good as conventional D&C. Okay. So what is medical curettage when we are talking of surgical curettage? Have you heard of medical curettage?
Yes, ma'am. Progesterone.
Yeah, when you give any bleeding woman high doses of progesterone, it will stop the bleeding, right? Initially, you give load them with up to 30 to 60 milligram of progesterone and maintain them on.
You decrease the dose and keep maintaining for 21
That
days.
is a medical curettage. Okay, so you do Pipel. And what is a special type of curettage? Any special types which we rarely do these days?
Fractional curettage.
To out of question, we don't do. And maybe sometimes I may have to do this conventional curettage also. Like some indications, can you tell me? She's bleeding heavily. So this only people I pass it on and scrape out some because of suction effect. I get some cells and send it for that may not be sufficient to give her a therapeutic benefit. Sometimes DNC could be both diagnostic and therapeutic. A woman who is continuously bleeding, endometrium is very thick. In those cases, I may have to do admit her and go through the proper conventional DNC where I have to give her a therapeutic benefit, right?
Yes, ma'am.
One exceptional condition. And what is another special type of curettage?
Fractional curettage.
Yes, tell me about though we don't do often, but it is better for you to know.
Ma'am, you ask the patient to empty the bladder and under suitable anesthesia, you in lithotomy position after bimanual examination is performed, the sim speculum is introduced, which will retract the posterior vaginal wall.
How many samples you take? That procedure is everywhere you do that, asepsis and all that. How many samples you take?
You take 2 samples, ma'am.
So we were doing some 6 samples, but that is no more practice. Now one we take from endocervix in the
Endocervix?
before I introduce a sound. And next I dilate the endocervical canal if required. Then I pass the sound to measure the uterocervical length and then I curate from the
Endometrium.
endometrial cavity. Why should I do this? Take separate samples? Because both endocervical lining and endometrial lining are columnar, but the malignancies are going to be different.
Management will also be different.
It's adenomatous type of adenocarcinoma of the cervix, where the management is going to be different, whereas adenocarcinoma of the endometrium, the management is going to be different. Okay, and they respond differently to surgery and the follow-up. So, but these days, we don't do, but there are better techniques like immunohistochemistry where they can, and some stains, Memantine stains, where they definitely tell this is endometrial cell and this is endocervical cell. That is the importance of doing fractional curettage. So you've done all that, and she has no other pathology other than her AUB. So how will you manage her now? And what other histopathology, when you send, what other histopathological pictures you may get? I've sent the endometrium for curettage. What histopathological features you may get?
Ma'am, it could be endometrial hypoplasia.
Most common type. Most common type would be our proliferative endometrium. You've done the endometrium. That is the purpose of doing that, DNC in the premenstrual phase. we have done in the premenstrual phase when you expect it to be a secretory endometrium, which is under progesterone effect, but you get a proliferative report, proliferative endometrium. That means that what? She's not ovulating.
Anovulation, yes, ma'am.
Anovulatory. And the next common would be progestational, maybe secretory endometrium. Other type would be pill endometrium. Other type would be, sometimes you may get tubercular endometrium. Sometimes you may get ariostolar reaction. Sometimes you may get, as you said, endometrial hyperplasia. What are the types of, it's very important for you to know endometrial hyperplasia. Types of endometrial hyperplasia, you know?
Without atypical cells and with
Yeah, the latest classification is, previously we were talking in terms of simple hyperplasia and complex hyper with and without it. But nowadays there's one simple definition: hyperplasia with atypia and without atypia. So what is the incidence of malignancy in each type?
3% in simple without.
Yeah, less than 5% in case of hyperplasia without atypia. It may go up to 30% in case of atypia, the hyperplasia with atypia. What is the other name given to this hyperplasia with atypia? Like CIN, they've given something. EIN, what is EIN?
Ma'am, it is endometrial intraepithelial neoplasia.
Intraepithelial neoplasia, that is the latest terminology. So you have done all that, and you simultaneously she was bleeding, and what did you give her to stop bleeding?
Ma'am, NSAIDs.
The first line of drug would be?
Line of treatment to control the bleeding will be NSAIDs like.
What are the NSAIDs you give generally?
Mefenamic acid, naproxen, ibuprofen.
How much you should give? There is always a problem with dosages. We come across many prescriptions. They give one tablet BID, one tablet OD, something like that. So unless you give a right dosage, so they will not respond to your treatment. So what is the correct dosage of NSAIDs? What are the NSAIDs you told? Mefenamic acid and tranexamic acid. Trenexa, it should be the dosage.
For mefenamic acid, it should be 500 mg TID.
Okay.
Whereas tranexamic acid should be
4 grams per day. 1 gram TID you may have to give when she's bleeding in the form of either in the form of injection or oral. To be given for maybe 3 to 5 days. Definitely you can say that she's not responding, or you can think of changing the line of management, right?
Yes, ma'am.
So you have to build up first line of drugs. You have to give build up her hemoglobin, do the endometrial sampling, and proceed with the definitive treatment. So what are the treatment modalities for AUB-A or in all these, AUB-A or AUB-M, AUB-L, the management, the medical management is almost same, right? Agree with me?
Yes, ma'am.
What is the medical line of management for AUB?
Ma'am, after first line of treatment, then you proceed to do hormonal treatment. To arrest her bleeding, you can give her progesterone pills like medroxyprogesterone acetate or norepinephrine, depending on
what age for medroxyprogesterone, which is the most potent progesterone for arrest of bleeding. Is it medroxyprogesterone acetate?
No, ma'am, it is norepinephrine.
Yeah. So, but preferentially in younger age group, I may consider giving medroxyprogesterone acetate because of less androgenic effect. I don't want her to develop androgenic features. So in those cases, I may switch over to. Otherwise, the preferred progesterone is?
Norepinephrine.
What are the newer progesterones you are aware?
Digest.
Third generation and fourth. Nowadays, it is fourth generation Dynogest, which is given 2 mg per day for 3 months. Okay, Dynogest, Desogestrel, Norgestimate. These are third generation and fourth generation progesterones with less side effects. So we prefer to go for higher and higher generations. Okay.
Yes, ma'am.
So progesterones you can give to achieve medical curettage, as we said. So not responding to that, then the next line would be?
Mirena, ma'am, LNG IUD.
Okay, not willing for Mirena then. COC, is there any place for COCs?
Yes, ma'am.
How long will you give this progesterone for adenomyosis or endometriosis or fibroid? A good 3 to 6 months would do. So during that time, they continuously, if you give COC for 3 to 6 months, what will happen?
Increase estrogenic effect.
So that kind of treatment is practiced in case of endometriosis. What do you call that as? She will achieve a state of pseudo pregnancy when she will not have menstruation and she will be in a state of pseudo pregnancy. What is pseudo menopause? Which medication, which injection or drug can cause pseudo menopause?
Any chemotherapy or any hormonal
We are
treatment.
talking in terms of medical
Ma'am,
management.
GnRH agonist.
Yeah, that will take
Leuprolide.
state of pseudo menopause, right? No. So that these two are concepts behind treating with continuous COC or continuous progesterone and GnRH, pseudomenopause and pseudo pregnancy states. Okay, anything else you can give?
Ma'am, SCRM like ormeloxifene.
Sometimes, they prefer to take an injection. What injection you give? What is the dosage?
Ormeloxifene.
Injection, 150 mg for every 3 months you can give, but that has got a lot of side effects in terms of irregular spotting or amenorrhea. Menstrual irregularities are also happen to be seen with, but so it's one of the modes of treatment. Okay. So if medical management succeeds, fine, you can continue. If it fails or woman has completed her family, what is the surgical treatment for your case?
Hysterectomy, vaginal hysterectomy could be done.
Is there any conservative line of surgical management?
Yes, ma'am. Minimally invasive surgeries can
She
be done.
doesn't want total removal of uterus. She just want, I'll retain my uterus for menstrual purpose for some reason, or
You can go with any ablative procedures.
ablative may not be very helpful because here the problem is not inside the endometrial lining, right?
Yes, ma'am.
It is the preferred one. If it's a focal adenoma, adenomyomata, you can go for adenomyomectomy. Or what are the other conservative surgeries like,
High intensity.
hypo,
Yes, ma'am. High intensity focused ultrasound or magnetic.
thermal ablation. So they've tried uterine artery embolization, all that with not very good success. Uterine artery embolization is definitely not indicated when she wants to conceive.
Yes, ma'am.
Right? Not an indication when she has to have baby, only retaining uterus, that too with lot of complications. So the definitive surgery is hysterectomy, which can relieve her from all the symptoms and it will definitely give you the final diagnosis. The adenomyosis final diagnosis is only achieved after histopathology, right?
Yes, ma'am.
So it's a 12-week size. She has opted for hysterectomy, which is the preferred route of.
Vaginal hysterectomy is always preferred over abdominal hysterectomy.
Yeah, you're right, because there is a vaginal route there is a natural route is there.
Lesser anesthetic complications.
Yes, but what is the disadvantage? Any uterus less than 12 weeks, that is the mandate. More than bigger size also, more than 12 weeks also, we have been doing after debulking, we do. But if it is, what is the disadvantage of doing BH? We cannot address, most of the times we will not be able to reach the adnexa, right?
Yes, ma'am.
If we can reach the tube, we can take out the tube. If there is any pathology in the tube, we cannot take out. So we want to reduce the incidence of CA cervix by doing CA ovary, by doing prophylactic salpingectomy. All that cannot be achieved by doing BH if you cannot reach the expert surgeons. They do that. They reach the adnexa and take out. But we can take the assistance of LAVH. What is LAVH?
Laparoscopic
We
assisted.
can laparoscopically release the upper pedicle like ovary and tube and proceed with rest of the procedures with the vaginal route. What is the next method? Next route after vaginal would be which is the last one?
Last one would be abdominal route.
Because of the lot of complications. So would you like to take out tube and ovary also along with the uterus? She's 44 years.
No, ma'am. Should retain the ovaries.
Why do you want to retain? What is the problem of retaining, or what are the pros and cons of retaining the ovary?
Ma'am, the con of retaining would be that she'll be at a higher risk of any malignancies.
What is the incidence?
Very rare, ma'am. Very less.
Like, not very rare. It's not so very rare also. In general population, it is 1 in 70. After hysterectomy, it is 1 in 100. You know, they're more common than malignant. They come with all these post-hysterectomy cysts and a lot of adhesions. And CS ovary is the one which we are worried, 1 in 100. But if I take out the ovary at 44 years, all 100 are going to suffer from iatrogenic menopause. I am giving her iatrogenic menopause, right? If I take out the ovaries at 44. So the current practice is not to take out the ovaries till the age of menopause unless they're diseased. You know, sometimes the ovaries continue to function even after menopause because there is always a conversion of androgen into estrogen.
Yes.
So, benefit to be given to retain the ovary till the age of menopause unless they're diseased. So, at age of 44, if I take out, she will definitely have, all 100 will have iatrogenic menopause and they suffer. So, if I retain, only one will suffer. So, that is justifiable. That is
Okay.
why it's always better to retain the ovaries and take out the
Uterus and
tubes. Salpingectomy you have to do, otherwise you will have what type of tumor? Serous intratubal cancer cells. Okay,
okay.
that is why you should always do salpingectomy, not oophorectomy.
Okay.
Understood? I don't know how much you answered most of it. You prepared well, Pranjal. Do continue to read well.
Yes, ma'am.
Prepare for other topics also. Whatever you did not know, I've
Yes,
answered and hope you have understood.
yes, ma'am.
It was useful to you and others, hopefully.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Hello, Divya.
Ha, ma'am. Thank
Any
you, ma'am.
questions in the chat box? I can't see any
Uh,
questions in the chat box. Anyone has asked any queries?
not, no, ma'am, not any questions. No, so we'll wind this up, ma'am. Thank you so much, ma'am.
Yeah, thank you, Divya.
Thank you so much for your valuable, giving your valuable time, ma'am. Thank you so much.
Okay, thank you, dear. Bye.
Thank you, ma'am.
Thank you, Pranjal.
Thank you, ma'am.
And Pranjal ಮುಖ ಕಾಣಿಸ್ತಾ ಇರ್ಲಿಲ್ಲ. It is not shown. ಹಂಗೆ ಕಾಣಿಸ್ತಾ ಇತ್ತು. ಅದೇ ಇದೆ ನೋಡಿ.